Hi, this is Greg. I want to spend just a few minutes talking to you about what the research says when we look at remote delivery or the distal delivery of case management. Online therapy is known by a couple of different names, e-therapy, etc. And it's a kind of a new concept where a therapist or counselor provides psychological advice and support via the internet. It's not so new, though, because it actually started back in the 1950s in the military, where because of the distance and the number of counselors available, telephone was used in the process. So telephone calls, video dialogues, email conversations, text chat dialogues, synchronous, asynchronous, all those kinds of things. These are all potential delivery methods for remote or distal delivery of case management. Now, the research on telephone and video is pulled from research that was completed in a therapeutic environment. There's currently no research on how telephone and video CBT delivery is happening in community supervision. So what we look for is the principles that cross over from a therapeutic environment to what we do in a community supervision. So how do you physical distance without social distancing? I don't like the word social distance because we still need to maintain relationships, social relationships. So let's understand the difference between proximal and distal and how we deliver in that setting. Now, just so you understand, all the research is based on professionally trained therapists. The skill training of the person delivering the distal or remote e-case management is foundational to the outcomes. If I have a person delivering remote case management who's not trained, then the outcomes are going to be expected to be very poor. So here's a review of available literature on the delivery of CBTs, behavior change, using an e-case management, and it's primarily going to be focused on telephone and video. This is from a dissertation research by Joshua Turner, and it focused on the use of telephone versus face-to-face. First, an advantage. It created anonymity and led to more information disclosures because this person was not directly face-to-face, so they felt they had the ability to tell me more about themselves. However, a disadvantage was feedback was limited because I'm missing verbal clues. We'll talk more about that when we talk about some skill development. Another advantage, there was a huge benefit versus face-to-face due to the distance, time, and work. And more clients were able to complete their treatment because they didn't have to travel and schedule. It was more convenient for them. Another disadvantage is that clients expected CBTs to be delivered face-to-face and not via the telephone. However, the research indicated that once they started the process, that went away. Face-to-face typically lasted 30 to 40 minutes, where the telephone typically lasted 20 to 30 minutes. So there's a shorter time frame using telephone. Another interesting fact is that face-to-face often digressed from goals, where telephone typically stayed more focused. There's some additional research done with medical doctors that talked about the focus of a telephone conversation versus face-to-face. Chadwick in 2006 talks about the fact that structure impacts therapeutic relationships. Keep that in mind. The more we move to remote delivery, the better our structures have to be. Face-to-face and telephone CBT provided comparable symptom improvements. And here's the interesting fact that the telephone clients tended to complete their treatments more frequently than face-to-face. I find that in all the research, we have a higher completion when we move to remote delivery than we do in face-to-face. Journal of Counseling Psychology in '02. This is some research by Reese, Connolly, and Brossart, and these average sessions lasted about 30 minutes. Now, I want you to look at some specific numbers. The specific improvement, the numbers, 77.4 to 82%. Statistically, that is almost identical. Global improvement, look, statistically, almost identical, 61.5 to 64. Satisfaction. In fact, the satisfaction levels were higher in telephone or remote delivery than they were in face-to-face. People were satisfied with the product. Telephone counseling respondents rated their counselors no differently than did individuals who experienced face-to-face. The social influence of the counselor maintained the same level whether it was remote or proximal. The mean bond score, which tells me the counselor relationship to the client, was a little bit higher in the remote delivery, but statistically not different. So some lessons from the study. Not all clients fit the e-case management system. Telephone counseling respondents who reported functioning very poorly at the beginning of counseling reported significantly less improvement than face-to-face clients. Keep this in mind. You need to assess the client because the client's level of functioning is key whether or not remote delivery is even possible. Another lesson from the study is that the effectiveness or the outcome for the client is connected to the length of time the client was involved. Short created poorer results. Longer terms of about a year created better results. Another lesson from the study is that additional training is required for remote delivery methods. Just the fact that I have an absence of nonverbal cues totally changes the way I structure the delivery of the CBT. The telephone removes many of the counselor's opportunities for social influence because the visual means are absent. Now here's some multiple sources of research that I've gathered just to give you some ideas that there is additional research available. According to Germain, back in 2010, CBT delivered via video conferencing is as effective as traditional in-person CBT with no significant differences in outcome. Keep that in mind. Remote delivery has zero difference in terms of effectiveness. In terms of individual engagement, a study conducted in 2013 found that there's a lower percentage of withdrawals and no-shows for video therapy compared to in-person settings. Well, this just makes sense. Clients can be engaged when it's more convenient for them. It's less intimidating. The degree of separation provided by video therapy, in contrast to face-to-face, has been shown to mitigate feelings of intimidation or loss of personal control that may be more prevalent in traditional therapy settings. So because I'm in a remote setting, there's distance between us, it's much less intimidating. Frequently cited benefit of online therapy is convenience and increased access. And we know that, especially with working remotely where I can't go into the office because of COVID-19 issues. Here's some of the challenges. Clients require quiet and safe space for video calls. We talk about distractions. Your clients must be in a distraction-free environment for remote delivery to work. Video therapy may not work for all clients. Clients who need extensive support between sessions, probably not good candidates. Assessing clients for suitableness is really important in remote delivery. Technical skills, both access and the skill set are really important, and there's some research that supports that. Nonverbal cues are very difficult to pick up on video. They don't even exist in telephone dialogue, but we have to be aware that many times we miss nonverbal cues, so our ability to connect is different. Here's probably the largest research that we have available to us. It's a metadata research. This is the largest research available to us. It's 17 studies, and the results demonstrated that eCBT was more effective than face-to-face CBT at reducing depression. So what we have is a comparison of electronically delivered and face-to-face cognitive behavioral therapies, and we discover, when we look at all the different research available there, that remote delivery is more effective than face-to-face. That is a huge, huge factor. The overwhelming evidence from current research is that electronic or remote delivery of case management is at least equal to, if not superior to, face-to-face case management. And if that's the case, evidence-based practice says we better start moving to more electronic or remote distal delivery methods because the research supports that it is more effective in today's environment. So COVID-19 is a crisis that opens the door to more effective methods. Who would have thought it? With 2020 being such a volatile year, at least we've discovered we have better options available to us. The question remains, are we going to use them? If you want these research articles, they're available from Greg, and please sign up for the Q&A, especially when it relates to the research. Those Q&A sessions will be via Zoom in November.